Hello, everyone. Hi, I'm Sachin Agarwal from New York City, Columbia University, and today I'm going to be discussing the health impact of COVID-19 pandemic on chronic survivors of cardiac arrest residing in New York City, and how the COVID-19 pandemic had the effect on their psychological, medical, and the effect on health behaviors that protect them from future cardiovascular events. I have no affiliation or any kind of funding from the industry. Most of the work was sponsored and supported by the National Institute of Health funding. So today I'm going to show you the results of our search conducting after the first week peak of the pandemic was over, and show how the anxiety associated with pandemic disproportionately affected the cardiac arrest survivors, and also how certain communities and the race and ethnicities were affected more. Also, how pandemic led to disruption of certain key cardioprotective health behaviors like physical activity, sleep, seeking medical help when they needed for their non-COVID related conditions, and how lack of access of care was present during the pandemic, and how it affected certain race and ethnicities, and people had to decide between staying at home versus going to the emergency medicine visits, and how our neurocardiac comprehensive care clinic in New York City have adapted to the new normal and transformed during this pandemic. As you all know, by May 3rd, 2020, there were 3.5 million cases worldwide, and US alone had 1.1 million, with NYC accounting for 5% of all cases worldwide, and also 7.5% of all deaths. Sometimes the numbers were as high as 800 deaths a day. As we could tell, that COVID not just had a direct impact on the health of cardiac arrest survivors, but also indirectly, it was seen that the heart disease deaths increased threefold in New York City. The pandemic disrupted the gains we had made in last decade in terms of cardiac arrest survival, and also the guidelines concordant cardiac arrest care. Further, during the peak of the pandemic, some of the hard hit states like New York City, the survivors of cardiac arrest heard a chilling message: help is not coming this time. NYC released this public health messaging where the health and safety of EMS providers was taken into consideration by limiting their COVID-19 exposure, and to conserve the hospital resources. It was advised that paramedics not to bring cardiac arrest patients to hospitals if they could not be revived in the field. So at Columbia University in New York City, we have a longitudinal study running for now 5 years, where we enroll patients from the ICUs and before hospital discharge, and then administer periodic cognitive, psychological, and neurological assessments during the first year of survival. So we received the permission from a local review board and reached out to our cohort of survivors discharged within the last 2 years, and invited them to participate in a telephone-based assessment of the pandemic's impact on their psychological and behavioral dimensions. So this was done a month after the peak was over. So we started the study May 15th and ended on July 15th. We measured the cardiac COVID-19 anxiety using the 7-item perceived coronavirus threat questionnaire as recommended by National Institute of Health. We used the International Physical Activity Questionnaire to measure the amount of physical activity in 7 days, both before and during the COVID-19, and then categorized into low, moderate, and high activity levels. Also, the sleep quality and the duration of sleep was measured before and after the period of peak pandemic, and we used the Pittsburgh Sleep Quality Index. So out of the 130 eligible, 105 survivors participated, 57% men. The average age was around 58 years. the Columbia University and New York Presbyterian Hospital is in Washington Heights, which is a very Latino dominated community. So we had 35% of the participants being Latino and 41% non-Hispanic white, with 18% blacks. The majority of the cardiac arrest survivors were at home. They were trying to avoid the social and maintaining the social visits and maintaining the distancing, and they were COVID-19 test negative and also the symptoms negative. The median COVID-19 anxiety score was 28, which is indicating that there was substantial anxiety associated with pandemic. So the first set of results I want to show you is that how the blacks and the Latinx participants reported significantly higher anxiety than non-Hispanic whites. We also noticed that responders who were moderate to extremely afraid that emergency care would not come if they had another cardiac arrest, that is 46% of the cohort fell into that category, and they had significantly higher COVID anxiety compared to the others. Not shown here is that this association was significant after adjusting for the demographics, age, race, ethnicity, sex, and COVID-19 testing status. We also saw that participants who said they were very to extremely likely to delay seeking care for non-COVID related conditions had greater levels of COVID-19 anxiety compared to those who said that they would go and seek care if it comes down to that. So the anxiety was definitely changing the behavior of our participants at home. Compared to pre-COVID, cardiac arrest survivors reduced their days per week of engagement in physical activity by average of 2 days. And the anxiety was the highest among those who previously were very physically active, but then now they are not doing low levels of physical activity. Every increase in cardiac anxiety score by 1 standard deviation, participants reported 30 minutes less sleep per night. And as you can see here, that 32% of the population of the cohort endorsed poor sleep quality, and they had higher COVID-19 anxiety scores. We also looked into how they were accessing their medical health, primary care appointments, urgent and routine medical procedures defined by medical care, physical health, rehabilitation services, home health services, because all of this was not there during the pandemic. And finally, the access to mental health, psychiatric or psychotherapy sessions. As you can see, most frequently reported was the lack of access to care for medical aspects in 55% of the cases of the participants, followed by 38% for physical and 14% for mental health care. The striking finding was that this lack of access to medical care was significantly and disproportionately greater in Blacks and Latinx patients compared to non-Hispanic whites. We also saw that despite the fear of contracting COVID-19, 21% of participants reported emergency medicine visits for non-COVID related issues, and several got admitted. Now, there were additional 10% of patients who developed serious cardiac symptoms at home but decided not to seek medical care. And we found that the patients who reported reduced access to medical care are the ones, and they were more likely to seek this emergency medical attention compared to those who had continued access to care, and even after adjusting for all the demographics and COVID-19 status. So we noticed that, concluded that COVID-19 anxiety was common, more frequent in Black and Latinx participants. The disaster-related public health messaging has potential to cause additional psychological distress, so we've got to be mindful of that. COVID-19 anxiety also led to poorer health behaviors. People were having low physical activity, poor sleep, delay in seeking emergency medical care, and the lack of access to care, especially for the medical aspects of the survivorship, led to increased emergency medicine visits and disproportionately affecting certain communities. So a reliable healthcare delivery system is warranted during these natural disasters. So this is our structure of our neurocardiac comprehensive care clinic, a one-stop shop that we started a couple of years ago. And the idea is to assess the psychosocial aspects, provide them psychoeducation as well as education about their disease condition, build their resilience, manage their medications, and also evaluate them for neurological complications. This is the structure of our clinic. It was used to be in person, where the survivor and the caregiver will meet all the different specialties that are required for survivorship, whether it's critical care, psychology, patient care services, research coordinator, everybody, so that we could actually get a wholesome, comprehensive assessment of our survivors and all, as well as the caregiver. So it was successful when it was done in person, and we really got a lot of attention because of that, and it helped a lot of people. And when we looked at the initial impact in our first year of 106 visits, we found that we were able to diagnose people with psychiatric disorders and treat them and get MRIs and EEGs and connect them to the rehabilitating services. And compared to the historical controls, the patients had better physical health, better mental health, low rates of depression, less negative impact on their marital status, and less fearful about the possibility of recurrence. So during the pandemic, we were transforming our system and our structure into more of a virtual, and New York Presbyterian Hospital was integrating the electronic health record system and utilizing the post-cardiac arrest clinic to provide access to basic medical care to our survivors. And then in the future, I think developing home rehab models via or telepsychiatry, use of wearable technology to monitor their physical activity and sleep, creating remote monitoring programs to monitor their vitals and any catastrophic events that led to the emergency medicine visits are all valid options. The biggest challenge remains that many potential participants probably do not even know what teleservices is available, much less they know that they are eligible for coverage or how to find these providers. And the health literacy issue is more prevalent in certain race and ethnicities as well as low socioeconomic statuses. So the availability of the technology alone may not be sufficient to overcome these barriers that we unearthed during our study. And we believe that additional interventions, additional steps need to be taken to really close this digital divide. So thank you for your time, and this is my email address and my Twitter handle. So please let us know if you have any questions, and I would be happy to answer any queries you have. See you later at the main session. Bye bye.